in the chat. It's always wonderful in these digital times to see with whom we're sharing space and speaking. So as Anna said, I'm the Executive Director of the Community Health Impact Coalition, which is really, if you haven't heard of us, a team of health organizations working in over 30 countries, from Guatemala to Pakistan, who've come together to make professionalized community health workers a norm worldwide. And what we mean by that is that we want to make sure that lay people who've been trained to provide health services in their communities are equipped, supported, and paid to do so. And we do that primarily in two ways. One, by identifying the practices that fuel quality care delivery, so research jointly across many different geographies, and then accompanying partners to adopt those practices. Actual knowledge translation, often something gets lost between the RCT and the Ministry of Health Policy, and we're trying to really bridge those worlds with this group of practitioners who are, again, simultaneously research and practice oriented. So you can see some of the places that we're all from in this coalition, and everything that I present to you today is really a joint piece of work by this group. So today what I want to do is in collaboration actually with one of my colleagues in Sierra Leone, Matu Jallo, who couldn't unfortunately be here this morning, but did record a video message for us. I want to speak with you about, as Anna said, how to support community health workers on the front lines of the global COVID-19 response. We're going to talk through first kind of what's at stake here, then strategies that are already being employed to support these workers, and then finally how you all can plug in regardless of your position, whether you're an academic, whether you're a practitioner, whether you're a ministry official, whether you're a student. I know there are all sorts of people joining this webinar. Whatever your role, we think there's something that you can do to support these workers and support the response, and that's what we'll be going through at the end. And of course, we'll also be sure to leave 30 minutes for questions. So without further ado, I want to just kind of set the stage for our discussion today. What we've already seen is that COVID-19 disproportionately affects the poor and the vulnerable. We've seen that in wealthy countries, we've seen that in low middle income countries, but we've also seen already since January, since March, that community health workers are poised to play a pivotal role in fighting the pandemic, particularly actually in countries with less resilient health systems. But the question is, of course, who are community health workers and how can we support them? So community health workers, as I said, are basically just lay people who are trained to provide health services in their neighborhoods to their neighbors. And they've been around for a long time, more than 100 years, and have contributed to really significant improvements in various health areas, like reducing child undernutrition, improving maternal and child health, expanding access to family planning services, and contributing significantly to infectious disease control for HIV, for malaria, for tuberculosis, in areas all across the globe. And rigorous studies, randomized trials, for those of you in the know, indicate that community health workers can, as indicated on this slide here, deliver health services not only as diverse as birth control injection to HIV care management, but that what they can do ultimately reduces child morbidity, child mortality, and that they can have a 10-to-1 return on investment. And that's at a national level if ministries of health make that investment in a robust and well-supported community health program. You see some references at the bottom for some of that information. So in this context, so obviously community health workers provide primary health care in their neighborhoods day to day all over the world. But in the context of an epidemic or a pandemic like COVID, CHWs are not only key to fighting COVID, but also to maintaining access to essential healthcare services during the pandemic, which we've learned from previous pandemics and what we're seeing already now is almost equally as important if we're talking about keeping people safe and saving lives. So to give us a bit of a more granular view of what's at stake, as I mentioned, my colleague Ramatu Jallo, who's a CHW supervisor with the Ministry of Health in Sierra Leone, recorded the following message that I think sets the stage very well. I'm just gonna play it for you now.
Hello, my name is Madeleine Ballard from Sierra Leone, a community health worker supervisor working with partners in health. This is not my first time working out there as a community health worker. Thank you.
So can you update us about the current situation in your country about the COVID-19?
Well, the communities, there are a lot of panic due to what they have been seeing in social media, because if the advanced countries are having dead cases, what about the local countries like Sierra Leone?
So what are the roles and responsibilities that these CHWs and supervisors are given to this community in helping the health system during this challenging time?
Well, the community health workers and supervisors, we are out there calming the situation down, because we are there educating the communities, because it's part of us already. This is not our first time. We are always out there because PIH have made us part and parcel of the community. So we are there calming them down.
So how important it is for CHWs and supervisors to protect themselves from this epidemic?
Well, it's very important for CHWs and supervisors to be protected, because when you protect one supervisor or one CHW, it's like you have protected thousands of communities.
Yeah. So what would be your suggestions and idea, and what do you think it will be important to share with the audience and even NGOs and some other founders and also researchers to come to your aid?
Well, all we are saying now, we need empowerment, we need support, risk allowances, because we are the frontliners. Just imagine if everybody is going to be indoors, we will be out there to visit even the quarantine homes. If it goes to that point, we have to be there, so we have to be protected. They have to give us IPP, they have to give everything that will protect us, because if we are protected, then our communities and villages or whatever around us is being protected. Yeah, the same time, I might say CHWs and supervisors should be more recognized. Yes, we know we are recognized, but not 100%, because they feel that because we are in the communities. But let me tell you, my people, CHWs and supervisors, we are the best, because if before the community people will reach the facility, we are the frontliners, we are the people that will lead them, we are the connectors, so we are more exposed, right? So we must be equipped, and we must be paid to motivate us more. You know, it's not easy. While someone is going to be indoors, then I'm outside there. Yes, I'm ready, I'm willing to fight the fight, because I'm a soldier for a situation. Thank you.
So as you heard there from Ramatu, when we're all inside, community health workers are outdoors, and that they're really the connectors, as she said, between the community and the health system. Before folks reach a primary healthcare center, they'll be able to see a community health worker. Community health workers are already there, and they're a trusted member of the community. When, as Ramatu said, folks are in panic, you know, they're a trusted source of information. But the wrinkle to this story that Ramatu was kind of alluding to repeatedly in her message there was that community health workers in many places are not supported and protected. They're not, as she said, 100% recognized to begin with, which makes, you know, supporting them to do the critical work and life-saving work they can do during pandemics all the more difficult. And so where do we go from here?
Hello.
Members of the Community Health Impact Coalition, including Ramatu, have developed and supported high-impact community health programs with governments and communities across the globe through multiple outbreaks, through multiple epidemics. And together, we've articulated 4 priorities for the COVID-19 response. And we put this out in March. It's now in a paper on VMJ Global Health, which is linked in the presentation. But effectively, we said, in order to have a successful response, we'll need to do 4 things. 1, we need to protect health workers. 2, evidently, we need to interrupt transmission of the virus. 3, we need to maintain existing health services. And 4, we need to shield the most vulnerable. And that should be kind of our litmus test for our response and the priorities towards which we're working. This, of course, raises the question, okay, what are the targeted actions needed at different stages of the pandemic to achieve these 4 goals? And that's what I'll spend a few minutes now just kind of walking through. How can community health workers be supported to play the critical role that they need to play in order to help us achieve these goals? So first off, if we're talking about protecting health workers, this is kind of really where it starts. And this is what, again, Ramatu was sort of saying repeatedly, that health workers need to be protected. And this is whether you're experiencing the epidemic in the United States or experiencing the epidemic in Nepal, the same is true. We saw early in the epidemic in Lombardy, Italy, that the infection rate is actually 12 times higher for health workers than the general population. And in many parts of the world, we've already seen CHWs and CHW supervisors like Ramatu being told to go work without any PPE at all. This has been widely covered, for instance, on the BBC and other news outlets with reference to various districts in India. And as has been said, I think repeatedly, Ramatu says, I'm a soldier ready for the fight, but that's kind of like sending a soldier into battle without any armor. And what we've been repeatedly saying and working towards is that PPE, personal protective equipment like masks and gloves and face shields, should depend on the service provided, not the service provider. And I think the impression that a lot of people have about community health workers is they maybe just only do health education, or they're out in their community, and so they're kind of a lesser health worker than nurses and doctors. But that's, of course, absolutely not true. As I've already explained, community health workers provide essential services around the world, and several services, like, for instance, providing an RDT for malaria, rapid diagnostic test, already require things like blood drawing. So they already should just be protected in their daily work by virtue of the things they're doing every day. And we're seeing that that's not the case. And now, given that they're the front lines in their communities, going door to door to door, the fact that they often don't have protection is really concerning. 1, because it puts them at risk, but also, of course, 2, that it could make community health workers themselves into a vector. And we're going to return to that later in the presentation, and hear again from some additional CHWs about their reflections on their experience with this. The problem is, as I said, in many ways, and as Ramatu said, community health workers are often not recognized. So they're often not included in country-level PPE projections. We did a piece of work a month or 2 ago, just kind of trying to quantify the unmet need for CHW PPE. And you can see that it's in excess of 4 million pieces of PPE annually to protect community health workers in just 24 countries in sub-Saharan Africa. And you can see the link to that paper below. But what we've learned is that either again, CHWs are not counted to begin with, or if they are counted and accredited within their country, they're often not included in the projections. Or if they are included in the projections, then whenever there's shortages, they bear the brunt of those shortages. And again, that's obviously completely unacceptable, and is an example of existing biases within the health system manifesting themselves in very unsafe ways during a pandemic. So it's critical that, 1, we fix obviously the absolute shortage of PPE. 2, that we address the inequity in PPE access. We've seen stories throughout the pandemic of rich countries outbidding poor countries. And again, there are even regional disparities within countries. And 3, that we address head-on the exclusion of CHWs from national projections, because they are just health workers like any other health worker, and they must be protected. Two, obviously we need to interrupt the virus. And I think it's pretty clear by now that every country that has planked the curve has engaged community health workers to conduct aggressive community contact tracing, and in many cases actually even transportation of samples for community-based testing. And again, as noted in the piece that's linked here in the slides, CHWs can prevent, detect, and respond to the virus. They can play many different roles, but again, only if they're protected and only if we are investing in training and supporting them to do so. And this is kind of some of what those roles look like. On the prevention side, obviously there's, as Ramatu said, community education, community engagement. There's an organizing component. The earliest community health workers were just community organizers, not extensions of the health system. And so they bring the community together to help create buy-in for projects like hand hygiene stations and other, infection control measures. Ultimately, as we look forward to what's to come in this pandemic, CHWs can also help lay the groundwork for the introduction of a COVID-19 vaccine. CHWs can also be critical in, again, detecting the virus. They, in many countries, proactively visit household to household and are experts in identifying signs and symptoms of various diseases. They can conduct COVID-19 testing if we ever get rapid diagnostic tests that work well enough. But again, they're already being used in sample collection and transport. Their skills are already being used in sample collection and transport. And obviously, community health workers in many countries play a really critical role in event-based surveillance systems, and this is no different. Finally, community health workers can respond, of course, to the existing pandemic by combating misinformation and by supporting their neighbors and community members as they undergo self-isolation or in the case that they have a deteriorating condition. I think this is increasingly critical in various countries as hospitals and facilities for COVID treatment and recuperation are getting overloaded. We're seeing the necessity to move towards community-based treatment and home-based treatment, and that's where CHWs come in as experts. The third priority is maintaining essential health services. And we think that what's been shown repeatedly, whether it's Ebola, whether it's COVID, is that the best health system is an everyday health system that can surge in a crisis. And that's because during times of crisis, essential health services often decline, which can ultimately kill more people than the pandemic itself. While everybody's focused on COVID, we see children dying of malaria, women dying in childbirth. So supporting community health teams will be key to ensuring this continuity of care. And there's evidence in previous pandemics to suggest that that's true. And in some countries, unfortunately, though, we've seen, for instance, in Nepal, we have folks joining from Nepal on the chat, CHWs in some areas being told to simply stay home. And that's, of course, unacceptable because that approach cuts the essential health services off at the knees and puts a huge number of people at risk. So we, again, are working in various countries, all the various organizations that have come together in the coalition to make sure that CHWs are designated essential workers, because that's really what they are. And we can see again that if we just look back to the recent Ebola epidemic, we see a really sobering picture: 50% reduction in access to healthcare, up to a 75% increase in maternal morbidity, mortality, and a 30% decline in childhood vaccination. So it's a really sobering picture. And in order to avoid a repeat, and we'll talk about the projections, you can see that these are projections for the current pandemic, COVID-19. in order to avoid these projected child deaths and avoid maternal mortality, as people are afraid to go to clinics, as hospitals are overloaded, a really strong community level response is critical for maintaining access, maintaining trust in the health system, and just keeping up with the fact that, I mean, this has been going on for months and months and months now. And of course, people are getting sick, they're having babies, life continues. So how are we, so supporting community health workers are critical to making sure that we are avoiding these scenarios. Finally, we need to shield the most vulnerable. As we discussed kind of at the beginning of this webinar, it's clear. It is clear. It happens in every pandemic. COVID-19 disproportionately affects the poor and vulnerable. So we need strong social support. That is part of outbreak control. It's not just a biomedical thing. It's a community thing. And in places where that don't currently have the resources to kind of cushion the pandemic's economic blow, investing in community health workers who can support their communities during isolation, during an economic downturn is critical. And obviously other mechanisms like immediate cash injections at the household labor level or at the community level are also critical in order to achieve this goal. So that was a lot. 4 big priorities: protecting health workers, maintaining essential services, ensuring that we interrupt the virus and protect the most vulnerable, and the community health workers' role in each. In order to kind of summarize a little bit what I've told you, we have another little animation here that I think can kind of bring it all together in just under 2 minutes. So I invite you to just sit back and take this in. So hopefully that gave you a bit of a sense of what community health workers need in order to do the work that, the critical life-saving work that we know that they can do. And I want to kind of conclude here today by talking a little bit about what everybody on this call can do to join the fight in supporting and standing with our community health worker colleagues. We have 6 suggestions for how you can act. And again, I want to emphasize that whatever your role, whether you're working at USAID, whether you're a ministry official, whether you're an academic, whether you're a student, various items on this list will be more or less applicable to you, but there's something for everyone. Truly, I believe that. So the first thing is, as evidence-based practitioners, this is a Johns Hopkins webinar. It's important to get oriented to the evidence. There is a lot of evidence on the role that community health workers can play in pandemics, and we've summarized it here and it's linked, and I think we're going to circulate this presentation after the webinar so you get all of these links. But there are existing reports that have already come out on the role of the community health workers in responding, and frankly, you don't even necessarily need to look on PubMed for that. We see in every country a community-based workforce doing contact tracing. So that's already evident, as is their role in maintaining health services. So learning how to support community health workers to prevent, detect, and respond, that's in the literature. We don't have to reinvent the wheel. A lot of these interventions have been tested already. You can check that out. I'd also invite you, again, if you have an interest in community healthcare in general, to subscribe here to the Community Health Research Roundup, which is something the Coalition puts out every 2 weeks, just a summary of the latest papers coming out around community health, not just COVID related, but in general. And I would say that, again, as evidence-based practitioners, we have to have a way to stay up to date with the literature, and that's a really easy way to do that. I think there's more than 1,000 people on that list, and we'd love to have you join it. The second thing, and this is more operational and immediate, is that over the past 20 weeks since March, the Coalition's actually been convening hundreds of implementers, or actually more than hundreds of organizations and implementers, possibly in the several hundreds, each week on a call, Friday, 11 a.m. Eastern, to solve for programmatic and operational issues related to the response. It's really easy to join us. These meetings are open to all practitioners. We have, again, people joining from Mali to Australia, so please do join us. And we've gone through everything from writing new protocols for community health workers, working with UNICEF to adapt existing ICCM protocols, trading notes on supply chain, organizing joint orders, whatever is most pressing in the response at that time. And I think it's shown really the power of open, transparent, real-time collaboration and response. So again, we invite you to join us for that. The third thing is, if you're in a position of power, if you, again, work in an NGO, work in a ministry, the time was obviously yesterday to start making concrete plans. That's an overwhelming task. There is support for that. Again, the targeted actions to protect, interrupt, maintain, and shield the vulnerable are cataloged in papers. We have, coming out of this call on Friday, a huge compendium of training resources that are being used in various countries right now in multiple languages that you can tap into and use. And so I would just encourage folks, I know there are at this point many compendiums, but that's another resource for you all. And particularly I would encourage folks, wherever you are, if you are in charge of a county or a district or even working in a national ministry, that this issue around registering and counting community health workers and making sure that they're protected like every other health worker is critical. And there is support for that. And I'll again reference that just in a few minutes at the end of this talk. The fourth thing is share resources. We've been hosting this live resource wiki, which again in March was being updated hundreds of times a day. At this point, it's a little bit slower, but it is a wonderful resource that includes everything from COVID explainers, internal policies, clinical protocols. And again, there is this also workflow resources protocol wiki for clinical questions, all organized, all table of contents. And those are two great resources too, as folks continue to encounter new clinical questions like, are we using DEX and things like that. So I'd encourage folks to plug in there as well. 5, and this is critical, this is the time to strengthen systems. I remember in my first sort of online faculty meeting when the shutdown happened in my area, someone mentioned, wait, wasn't it after World War II that Japan got universal health coverage? That's correct. It was after Ebola that Liberia made significant investments in their community health worker program. Also correct. Often out of crisis, we are able to take giant leaps forward in terms of equity and in terms of care. So this is the moment to use available tools like the CHW AIM tool, which is a tool for CHW program planning and quality assessment, or the MSH UNICEF costing tool, which is also critical for district and regional planning, to make sure that everyday programs are equipped to respond in an emergency, or that if a program is being started, a community health worker program is being started for the purposes of contact tracing or whatever the case may be in the pandemic, how can that be supported and strengthened over the long term to help maintain services and help increase access in rural areas or for vulnerable populations. This is the moment. It may not seem like it, but we really firmly believe it's the moment to make big plans, and we see a long history of that being the case. And there are, again, we don't have to reinvent the rules, the wheel. There are tools that can help make sure that CHWs are set up for success, and it's only a question of accessing them. So two really good ones are linked right there. And then finally, and this is the note I'll close on, we need to advocate. None of us are safe until health workers are protected, and the time to start is now. There is a global shortage of health workers that's expected to grow to up to 18 million health workers by 2030. Post-COVID, that's probably going to be even worse. How can we stand with our health worker colleagues and protect them in this time? A lot needs to be done, but of course it's possible. And so I want to share this final video message from some colleagues across the coalition and their reflections on the importance of personal protective equipment for CHWs.
My name is Fiti.
I'm Unita. Monica Adiambo.
Awoni Akira.
Frida. Unita Doyo.
My name is Caroline Mudoni Njomo.
I'm a community health worker.
I'm a community health worker.
We, the CHWs, are the frontiers in COVID-19.
We are linking the community with the hospital.
We are the key to building trust.
And when we are not going to meet with our clients because we don't have PPE, we are going to put the community in the risk of getting malaria,
HIV infection,
deaths of under 5,
maternal, perinatal deaths, immunization defaulting.
We work from house to house. So when we go there barehanded, how do we look? People whom we visit see us as if we are the people who are transmitting this disease.
Without the protecting devices, I'll put the community members at risk. At the same time, I'll also be putting myself at risk.
The biggest challenge responding to COVID-19 has been the lack of essential protective material like masks and gloves.
The pandemic is real.
I'm advocating for fellow community health workers like me to be given PPEs.
We need protection like other health workers. Why are we not being considered as health workers?
I need to protect myself. At the same time, I need to protect the community members.
Minus the protective, we can't do the work properly. How do you want us to be safe? We are unsafe. Give us the PPE.
We need to fight this virus.
So that is just a message from, again, many of the community health workers that are part of this coalition and with whom we work every day, demonstrating how dire this situation is, and reminding us that even as we face our own crises in whatever community we live in, again, whether you're sitting in Nairobi right now, or whether you're sitting in Geneva, or whether you're sitting in Toronto, this pandemic is not over until it's over for everyone. Never has it been more clear that the strength of our neighbor's health system is the strength of our own health system. And in order to do that, we need to protect health workers. And so I actually invite you, I can't share it with you yet, but
my name
Tuesday, so in just a couple of days, there will be a big announcement about how you can get involved in a pretty giant effort to help get personal protective equipment to all health workers, including community health workers across the continent. It's a big collaboration of 40 organizations, ministries of health, and it's embargoed, so I can't share more than that, but I would encourage you, if you're on Twitter, you can follow the coalition and you'll get all the information there. Sign up on our website. You see that's in the chat box to our mailing list. And there'll be steps again for you to take to get involved in that effort too. It is a huge multi-country effort, and we're really, and frankly, long overdue. So that's what I'll say on that. To conclude, I would just remind us that, you know, I think COVID-19 is a moral litmus test, that when everyone is vulnerable, how we commit to the lives of the most vulnerable, the lives of the poor, is how we'll be judged. That all of us have a role to play, and that honestly the urgent need for universal health coverage worldwide couldn't be more clear, and that the investments, luckily, in compensation, as Ramatu said, in dedicated supervision, in continuous training, in performance management necessary for a rapid community COVID response are the same that are required to prevent the next pandemic and provide really high quality healthcare access in the meantime. So we think that it's important to strengthen high quality healthcare delivery systems now more than ever, because they'll save lives, not just during COVID, but always. So feel free to, my email is here, Twitter, contacts, reach out. I know we have just under, about 20 minutes now to have a good chat together and ask questions, but if there are any documents or things that you want to see from the presentation, again, I think Anna put the link on where it'll be posted, but feel free to reach out directly as well.
Thank you so much for giving us that talk, Madeleine. That was great. And I think you really walked us through all of the different roles that community health workers can play. But I think also really focused on how they're under supported. And we've got some questions about that. The first question came from Jessica Barbie, and it was really around the PPE shortage issue that you mentioned. So she says, if there's a shortage, which is a problem that may arise and mitigation needs to be addressed before the problem arises, what are frameworks or recommendations for delineating PPE? Is there literature or suggestions that you can point to? This is a difficult topic to discuss, but a necessary one.
Yeah, absolutely. So, so I'm not a supply chain and operations expert, but we do work with several in Mozambique and DRC, in the United States as well. And I think what they would say, and I'm even happy to circulate some papers on this after the webinar, is a couple things. One, that obviously, just as humans in every context, we don't do a good job of planning for emergency response. We do a lot of investments immediately post any emergency, whether that's a hurricane, whether that's a pandemic. And then these investments get routinely cut in subsequent years as we sort of feel the urgency less and less and less, to the point where, again, we wake up, we're in the middle of a pandemic, and everybody realizes that they don't have enough PPE stocked to respond to it, which is particularly pernicious because, you know, PPE takes many years to expire. So it's something that's actually, it's really hard to overstock, actually. And so a couple things I would say. One, when I spoke about this in the presentation, I sort of said, you know, we see three priorities now, and I think these are three priorities to urgently respond, but also three priorities that can help us guide preparation as well, is that, you know, obviously there's an absolute shortage. So how can we kickstart local manufacturing, additional manufacturing, to close that absolute shortage? And I think we've seen a lot of creative ways to do that. You know, Bauer Hockey suddenly making face masks. We obviously need to set up that supply chain so it can surge without needing to, you know, derail hockey companies. And also set it up such that it doesn't all come from China and need to be shipped, because that's a big source of delays as well. So the more that, again, there's local manufacturing, the better. And there are initiatives right now to support that. The second thing is we need a marketplace and market shaping for this. And that's what I was talking about in terms of the inequity of access. This is a good lesson for us as the vaccine is about to come out. Similar dynamic. If we don't have equity mechanisms in place globally. And again, there are some like the WHO Solidarity Fund and others to make sure that everyone can access things. It's very predictable. Rich countries outbid poor countries. Rich countries stockpile, which is frankly, I think, immoral in a crisis. And you know, nothing changes. So that is a concern. And again, something that would be mitigated a little bit by local manufacturing. And thirdly, I think we need to have estimates of who needs what. And I think that's one of the things I want to try to drive home today around community health workers is if you have a large volunteer workforce made up primarily of unpaid women, when it comes time to, you know, that we need to get them something, we can't get to them because we don't know who they are or where they are or when they were last active. And so that's unacceptable. So I think if you're relying on people but not supporting them day to day, then it becomes really difficult when you need them to support them. So having those ducks in a row in terms of strong coalitions, in terms of you know, accreditation mechanisms, in terms of registration, et cetera, can also help in a crisis and help projections. Because again, this is what we saw repeatedly, that a lot of these projections the countries were making were wrong because they even in the midst of a crisis, because they excluded a whole really essential health cadre.
So I really appreciate some of those last points that you made, largely around relying on people who we don't pay and don't support, right? And this is a major part of a lot of global health programming. So I would wonder then about your thoughts on how you think the community health worker model of care might change in the future post-COVID-19. What might be some lessons that we're learning now, perhaps unique to the pandemic, but perhaps not, perhaps that are just being highlighted by the pandemic, that might help to change future models?
So I think, you know, community health care has been around for a long time, and it's always been important. One, even in the wealthiest, fanciest health systems, because it's not second best care. It is the standard of care for preventative care. Like if you want to, you know, lose weight or quit smoking, visiting a doctor every couple of months is not going to help you. Having a neighbor that comes and accompanies you on that journey, much more likely to lead to success. Secondly, it's critical for chronic care. If you have HIV, again, I think Dr. Paul Farmer is really famous for saying, you know, I wish that the HIV care in Boston was as good as it was in College Haiti. And that's not an exaggeration, because in Haiti, they rely on community health workers who are able to work with people in a high-touch way to overcome stigma, to overcome socioeconomic issues around, you know, not being able to take these really aggressive drugs because they are on an empty stomach, and solve some of those problems. The alive and in care rate in various parts of Haiti is, in fact, much higher than the alive and in care rate for some populations in Boston. So I think there has been a paradigm shift in some ways around this not being second best, this not being something that quote unquote poor countries do, but this just being something that actually they're just much better at than rich countries, and rich countries need to learn from them. And that's, you know, not reverse innovation, that is just innovation. And like we can learn from all people in all places. And certainly countries like Liberia, South Africa have a lot to teach us, because again, they had to deal with HIV, they had to deal with Ebola in a way that not every country did. And as a consequence, again, I think they're much better set up to deal with pandemics. But the critical thing, and again, that like Liberia has realized, is you need to pay and support these people. If you had a factory and you didn't supervise the workers, you didn't pay the workers, you didn't provide the workers the essential tools they needed to do their job, I'm not sure what the product would look like. And yet these are the types of expectations that we often bring to health systems, that we're just going to somehow have an informal and supported cadre that's out of stock, you know, some estimates say 40% of the time, and get healthcare to people. That's not how it works. If you look at the trials that have captured this, there's a huge difference between community health workers that are well supported, which is to say paid, continuously trained, in stock, supervised by a dedicated supervisor, versus those that aren't. We're not talking about the convertible of community health worker programs. We're talking about what are the, you know, essential components to have an engine that's running. And I think this is, again, Ebola now, again, another reminder that these are critical investments that ultimately save money in the long run. and they need to be prioritized.
Janine Nichols is asking a question that's pretty related, which is around how do we leverage COVID-19 finances to finance community health workers, and maybe suggestions you might have for people on the call who now have access to these type of funds and what they can do.
Yeah, absolutely. I think there's a long history of using vertical funding, so funding for HIV, funding for a particular pandemic, to build health systems, and that's what I would encourage. And that, again, what we've seen in Liberia, what we're seeing right now in Malawi, in a lot of places that often it seems counterintuitive, but often systems are built in crisis. And so what I would say is using tools, again, like that MSH UNICEF costing tool, like the CHW AIM tool for program planning and program assessment, to make sure, okay, do we have all the components listed in the CHW AIM tool around recruitment, around supervision, around training, around payment in place? And if not, can we fund them with these COVID funds? Because again, these community health workers are a key part of the response. And certainly that infrastructure that you set up in terms of, okay, we're going to equip them with mobile tools, or we're, loop them into the, the event-based surveillance system in the country, or into data flows that they weren't previously part of. Those investments last well beyond the crisis. So I would say it's an opportunity to build. And certainly, yeah, again, I would encourage folks to reach out to me directly. Happy to, if there are any ministry district representatives on the call, connect you with other representatives in other countries that have done this, and can provide more specific tips based on your particular funding flows or situation.
Great. And I have been posting some of the links that you gave throughout the PowerPoint into the chat box, so people should be able to access them there. There was a reminder with all of these calls, we always post the PowerPoints and a recording of the video on the Center for Global Health website, so that should be available within the next 2 days. So people can come back and check for all of that, and take notes of all of the dates that you've said, Madeleine, of things to be aware of, to get involved with, like the Friday calls that you mentioned as well. There's a question from Jennifer Gilbertson asking if you're aware of any interesting innovations to support community health workers during COVID-19 that could be scaled into community health worker programs.
So I'm a little bit old school on this. Really good innovations are paying people and continuously, and accrediting them, and continuously training them, and keeping them in stock. So a lot of that stuff is nuts and bolts that we know how to do, that we've done with other health cadres, that we do in lots of industries, that we just don't do for community health workers. And that's a political problem. That's not a technical problem. So I would start by saying that. I would say though, that some of the constraints that COVID is creating in terms of, for instance, not being able to gather together live in person in groups is really accelerating the uptake of, for instance, mobile training. And there are great resources that existed and were in place before the pandemic, like the Community Health Academy, that have only, the uptake is only accelerated during the pandemic. So whether it's, again, training, Community Health Academy, COVID-19 digital classroom, 2 great resources. Again, we can share those links. Or again, event-based surveillance, or temperature checks for health workers, those types of things. Folks like Damagi, folks like the Community Health Toolkit, which is stewarded by Medic Mobile. All of those technologies, again, existed before COVID, but we're seeing huge uptakes and huge uptake, and also new use cases for them. And so I think those are the most promising innovations that, in terms of just being able to, build a system that is relevant and lasts beyond the pandemic and strengthens universal health coverage in general.
One question I have for you, I think this comes up quite a bit, is that because we continue to rely on community health workers, we're also finding that increasingly they're overburdened, right? There are so many things that we're asking them to do. Based on your experience and conversations that you've had with community health workers and this COVID-19 pandemic, what is the current experience like trying to work with this pandemic, but also maintain all of the other types of tasks and work? I mean, we saw a little bit of this in the video, but it would be great to hear some more from you about the experience and balancing workloads and approaches.
Yeah, so I think the biggest challenge, and Ramati, you kind of alluded to this, but again, I think a lot of you need to, and other folks that were in some of these videos would say, is that workflows had to change. So a lot of folks are now, just the essential services, and one really negative way in which they changed is for those community health workers that got PPE, they were able to continue to they were able to keep safe and keep serving, able to continue to provide malaria care up close and do rapid diagnostic tests and do all the things, provide that essential care in the community like they were already doing. For those that, were told to stay home or not able to access PPE, that's proven to be one of the biggest bottlenecks in the response. And so it wasn't a question of being kind of overburdened. It was a question of, wow, now I'm so constricted. I can only do no touch protocols, which means that actually I can't provide, for instance, birth control injections or routine immunizations or a lot of things. And if you look at some of the data from Gavi, like there's been a huge drop off, and we'll see the health effects of that really shortly. So yeah, there's two different stories unfolding. Where health workers are equipped, obviously it's an additional strain. I think everybody in healthcare has been taking on additional tasks. Post-pandemic, there are tools like the USAID C3 tool or even that MSH UNICEF costing tool that are good at helping to estimate the time it takes to do various tasks and whether we're asking too much of various cadres or whether you need to, again, depending on the setup of the health system, whether you need to have certain healthcare workers that are only doing one vertical task and then a generalist in each area, or whether a generalist can take care of everything. It really does depend a little bit epidemiologically, but it's certainly a concern. But again, it's not a concern that's unique to community health workers. It's just something that we need to be aware of. And I would say that there are tools to sort of manage that. And there are studies kind of doing time capture that can help inform some of those decisions. And certainly community health workers themselves can tell you really well when things are going great in their jobs, and if they have dedicated regular supervision, they're able to escalate any concerns up through the health system. So again, that just points to the necessity to have a strong system that's able to adapt.
And then I think the other bulk of questions, I mean, we've talked about PPE so much. So I think, some people are asking about quality of PPE or being able to access or recycle PPE, or even thinking through different type of local manufacturing, right, which you described as being important. And maybe, I mean, it's so broad. I think if I were to ask each question specifically, it might be challenging because, again, you said you're not a supply chain expert. But I think it could be helpful if you just maybe reiterated some of your points about PPE, about where, what people who are working in programs at different levels can be thinking about in terms of getting PPE to community health workers, or what considerations there might need to be on the ground for PPE. So I know that's exceptionally broad, but I'm just seeing so many questions come in that maybe just sort of like a bucket response might be helpful.
Sure. So let's just start with the day-to-day usage of PPE. If there is PPE, there's a lot of guidance that's come out from the WHO, from the CDC, elsewhere, that is actually all kind of summarized in that protocol wiki document, which again, maybe we can toss that in the chat, but about extending the use of PPE. And we've seen this in hospitals in New York City, and we've also seen this in hospitals in Maputo. Most community health workers that we work with day to day are saying that they're given 1 or 2 masks per day, or they're either switching smocks or spraying themselves in between patient visits, or they're just simply not taking off the personal protective gear, and that's been working. And again, there are concerns about humidity. There's also concerns about disposal, which can be difficult, especially in rural areas, but that's where biohazard bags are helpful. Anyway, there's obviously a lot of considerations, but I would say, one, that there is guidance about extending the usage of existing PPE, which has been really helpful. Two, that it's important to know to fight for real PPE. Again, there are also summarized in this protocol document. There is studies on this, cloth masks versus surgical masks versus N95s. Cloth masks are not appropriate for healthcare workers. We've seen some murmurings about maybe they should be, or actually that in a lot of countries that's already what's being used, but we should continue to fight for the highest standard. Don't be hoodwinked on that. And then three, as was indicated by those estimates, this is just, again, that's 400 million pieces of PPE for just 24 countries for just one cadre. So again, the need is huge. There are multiple initiatives underway to try to move PPE, produce more PPE, again, from the Solidarity Fund to work by Africa CDC. There's another one, as I mentioned, that's going to be announced on Tuesday. What's clear is we need multiple complementary efforts, and that we need to be working with really good partners. Folks like Direct Relief, folks that have had existing supply chain relationships for many years, many decades. I think there was an article in the Washington Post just the other day that said, a couple of the suppliers that were approved by various government officials were only created a couple of weeks ago. We saw some large US companies procure fake PPE. So it's certainly a real concern, but there are, but that's why, again, that's what I think everything always, find the experts, find the folks that have been doing this for a long time and leverage their expertise. And again, there are resources out there in terms of approved supplier lists, et cetera. I think some quick considerations we've heard is finding people that have already shipped to your country that know how to deal with customs, working with chambers of commerce in different countries. In China, there's a list of approved suppliers, et cetera, et cetera. Again, it's a really deep topic. There's a lot on it. That protocol document's a great place to start. Lots of good links in there to a number of these questions.
Great. Well, thank you so much for that. I think we'll wrap up today's session there. Just some key points is pay your community health workers, and maybe that's an important takeaway, and for us to be focusing on providing PPE to people who are health workers, right? I think that's, you really, I think community health workers can sometimes be considered not health workers, but it's in the name, right? And they are providing healthcare to community members. So thank you so much for your talk today. We will be posting all of the links that Madeleine suggested on the Center for Global Health website, which was linked in the chat. We'll be providing the PowerPoint today in addition to recording of today's session. Our next seminar session is next Thursday, and it will be an update on COVID-19 therapeutics and prophylaxis. So we hope you'll join us for that session. Madeleine also provided her email. That was very kind of you, and her Twitter handle there as well. Oh, Madeleine, you just did it to all panelists, so I'm going to copy that quickly and send it to all the attendees.
Oh, sorry.
No worries. So now you should all see from me her email address and her Twitter, so you can reach out to her directly. Thank you again, Madeleine, for taking the time today, spending with us this morning to discuss this very important issue. We really appreciate it.
Thanks so much, guys.
All right, thanks everybody.